The point of, the focus of this conference is the top 10 advances in clinical cardiology. And the organizers of the conference asked me to speak about our heart failure guidelines with regard to evolving concepts. So what I want to do is just draw your attention today to things that have changed recently with regard to our heart failure guidelines. I don't have any disclosures. So our therapies for heart failure span a lot of different types of therapies. These include medical therapies, as those of you who are electrophysiologists know, not just ICD for prevention of sudden death, but also CRT therapy. And then on the right, you see surgical therapies, including ventricular assist device therapy, as well as cardiac transplantation. I'm going to focus your attention today solely on the medical therapies. These are our ACC/AHA guidelines based on stages of heart failure. You're all very familiar with these. We've been using the stages of heart failure ever since 2001 as a framework for thinking about heart failure therapies. And these were our guidelines up until just this past May, when newer guidelines and updated guidelines were released online. What I'm going to talk to you today is about stage C heart failure. These are patients who have symptomatic heart failure. They've had symptoms at some time. You can never go backwards with regard to stages in heart failure. In other words, you can't regress from stage C back to B, even if you become asymptomatic. So we're going to focus on our therapies for stage C, people with heart failure who were symptomatic or are currently now symptomatic. This is one of the best diagrams in our heart failure guidelines, and I ask you to look at it carefully when you have some time, because in this picture you will see all of the therapies that we use for HFrEF. That's heart failure with reduced ejection fraction. I'm speaking today only about HFrEF therapies. There are some exciting advances in HFpEF, heart failure with preserved ejection fraction, which is the type of heart failure we see in a little bit over half of our patients, more common in the elderly and in women, and include many of our hospitalized patients. There's some exciting advances there, but we're not going to talk about that today. So current therapies for HFrEF, for those who are symptomatic, of course we know that each of these patients should be on ACE inhibitor or angiotensin receptor blocker and a beta blocker. And then if we go down the left-hand side of the slide, those patients who are symptomatic with HFrEF and are volume overloaded require diuretic therapy. Down the middle of the slide, for those patients who are African American and remain symptomatic, the fixed dose combination of hydralazine nitrates is indicated. And on the far left, the addition of aldosterone antagonists for those patients who are already on ACE inhibitor or angiotensin receptor blocker plus a beta blocker and remain symptomatic benefit from the addition of an aldosterone inhibitor, both from the standpoint of symptoms, hospital admission reduction, and also survival. So what kind of bang for our buck do we get with these various therapies? This is a really important slide that's based on the results of SOLVE, CHARM, and you can see the other trials that are listed. The angiotensin receptor blocker and ACE inhibitor get us about a 10 to almost 15% reduction in mortality for those patients with HFrEF. Beta blockers, huge reduction, 35%. Mineralocorticoid receptor antagonists, 30%. I haven't shown you the compilation of the risk reduction with all of these therapies together, but we know that they are additive, and it is based on all these trials that our current therapies for heart failure have come into place. But let's talk about one of the newer therapies now. I draw your attention to an enzyme which is known as neprilysin. It degrades many endogenous vasoactive peptides. You can see them listed here: natriuretic peptides, bradykinin, substance P, etc. Neprilysin degrades these vasoactive peptides into inactive metabolites. But look what we get if we inhibit this enzyme. We see a decrease in neurohormonal activation, in vascular tone, in cardiac fibrosis, and the development of hypertrophy. And there's also a significant reduction in sodium retention. We remember that the basis of the development of heart failure is with any type of myocardial stress or vascular injury, we have a process called remodeling that goes on, and our goals are really to reverse remodel with all of our therapies. So if we were to attack the problem in two different ways, block both the angiotensin receptor and neprilysin as well, what happens to the evolution and progression of heart failure? Well, one such agent, LCZ696, is a combination of an angiotensin receptor blocker as well as a neprilysin inhibitor. And it was this particular drug that was developed to look at whether or not the combination of these two agents would have additive benefits in treatment of HFrEF patients. The Paradigm Heart Failure study was the major study that addressed this question. In the study, LCZ696 at a dose of 400 milligrams daily was compared directly to enalapril 20 milligrams daily, and this trial was specifically designed to replace the current use of ACE inhibitors and angiotensin receptor blockers as the cornerstone treatment of heart failure. This was not an equivalence trial. This was a trial to see if the blockage of both the angiotensin receptor and the neprilysin would be beneficial. The primary outcome of the Paradigm Heart Failure study was cardiovascular death or heart failure hospitalization, with secondary outcomes of cardiovascular death and heart failure hospitalization. There were several secondary outcomes as well: death from any cause, all-cause mortality. Symptoms are important. Doesn't matter how long we live if we feel terrible along the route. So the Kansas City Cardiomyopathy Questionnaire was used to assess patients' symptoms and physical limitations. There was a concern that neprilysin inhibition would result in higher incidence of atrial fibrillation, so that was tracked as an outcome. Also concern about, with this dual inhibition, would we see worsening renal outcomes? So this was tracked as a secondary endpoint as well. The entry criteria for the Paradigm Heart Failure study are important. Patients had to be symptomatic with heart failure. They had to have class 2 to 4 symptoms. Ejection fraction initially had to be less than 40%. This was decreased to less than 35% about midway through the trial to enrich the trial population. They had to have elevated BNP or NT-proBNP, but these levels could be 1/3 lower if a patient had been hospitalized in the prior year. Patients could have any use of ACE or ARB to get into the trial, but they had to tolerate a stable dose equivalent of at least 10 milligrams of enalapril daily for 4 weeks before they were enrolled. Patients had to be on guideline-recommended doses of beta blockers and mineralocorticoid receptor antagonists. And you can see that they had to have fairly substantial blood pressure to get into this trial. Blood pressure systolic had to be higher than 95. They could not have renal insufficiency, nor could they have a potassium higher than 5.4 at the time of randomization. This is the randomization scheme. There was a single-blind run-in period. Initially, patients for 2 weeks were on enalapril. They were then on each successively doses of LCZ696, 100 BID first, then 200 BID. It was only those patients who could tolerate the run-in period who were then randomized in a 1-to-1 fashion between LCZ696 and enalapril at the doses that you see. I already mentioned the secondary endpoints. And here's who was in the trial. Over 10,000 patients were screened in 47 countries. This was a huge study. Some patients, you can see, did not fulfill criteria for randomization, and those were excluded. But overall, 8,300 patients were randomized in this trial, and you can see equally between study drug and enalapril, with a median follow-up of 27 months. This was an extremely well-done study. very few patients were lost to follow-up, 11 in one group and 9 in the other. So congratulations to the investigators. It's always important to think about who was randomized in a trial when you try to consider later whether or not your patient who's sitting in front of you would benefit from a given therapy. And these are the patients who were randomized. Predominantly men, as is common in HFrEF studies, about 21–22% women, that's common. You can see the numbers of ischemic cardiomyopathy. You can see the functional class. Importantly, about 70% of patients randomized had mild heart failure symptoms. They had class 2 symptoms. The mean systolic blood pressure, pretty substantial in this patient group who had HFrEF, 122 millimeters of mercury. In addition, you can see the medications patients were on, pretty good heart failure medications, lots of beta blocker use, not too much mineralocorticoid antagonists, although this is what we see in general population studies as well. Importantly, probably because the study was done primarily outside the United States, very low use of ICD or CRT in the patient population studied. This is the primary endpoint of the Paradigm Heart Failure Study, cardiovascular death or heart failure hospitalization, a 20% reduction with LCZ 696 compared to what we previously knew was our guideline recommended drug, enalapril. Cardiovascular death, 20% reduction with study drug compared to enalapril. And then hospitalization for heart failure, we look at the primary endpoint, cardiovascular death, and then as Dr. Chazelle was saying, we know that hospitalization is coming under greater scrutiny. Significant reduction in hospitalization for heart failure with this medication as well. I know you can't see the subgroup analysis for both the primary endpoint and cardiovascular death, but for every pre-specified subgroup in the Paradigm Heart Failure Study, there was benefit compared to the enalapril, every pre-specified subgroup analysis. This was all-cause mortality. You can see again, LCZ 696 compared to enalapril resulted in a decrease in all-cause mortality for these patients. So remember what I said about the secondary endpoints. We really want to know whether our patients feel better and are doing better. Again, doesn't matter if you live longer if you feel worse, but if we look at KCCQ clinical summary score at the 8-month mark, there was a significant benefit for LCZ 696. The concern about new onset atrial fibrillation turned out, at least in this trial, to be unfounded, that there was not a higher incidence of AFib in those on study drug. There was also, by protocol-defined renal dysfunction, not an increased risk with the patients on LCZ 696. There was a lot of concern with regard to adverse events about symptomatic hypotension with study drug. As you can see from this data, there was more symptomatic hypotension in the study group compared to the enalapril group. However, there was not an increase in discontinuation for severe adverse events. Also, pretty significant concern going into the trial for angioedema, but it turns out that there was no difference in the enalapril group versus LCZ 696 in the development of angioedema during follow-up. So, the summary of the Paradigm Heart Failure Study for those patients with HFrEF who were fairly ill, documented by both biomarkers and previous hospitalization and/or previous hospitalization, LCZ 696 was more effective than enalapril in reducing the primary endpoint of cardiovascular death and heart failure hospitalization, incremental reduction in cardiovascular death by 20%, heart failure hospitalization incrementally by 21%, and all-cause mortality by 16%. And in general, as I've already stated, it seemed to be better tolerated than enalapril by several different measures. So remember the study or the slide I showed you previously about what bang for our buck we get with these therapies. Remember that we get a 20% additional reduction in mortality over ACE or ARB with this new agent. So there was some interest in looking at age group, and these were investigators who looked post-publication of the Paradigm Heart Failure Study just to assess the effect size according to age group. And to summarize this data, there seemed to be benefit in all age groups, both elderly and younger patients. This slide shows what our updated guidelines, again released online in May, have, where we've placed the guideline writers chose to give a recommendation to the use of the ARNI, which is, in this case, there's only one available, which is valsartan sacubitril, and basically letting us know that we can use this rather than ACE or ARB in our patients, and then as a, both for initial therapy and also for replacement therapy in those patients who are already on ACE and ARB. So this is the way the guideline writers looked at it in our recent update, but I think we should also think about some other things about this therapy as we try to apply it to our own patient populations. And this is how I really analyze this data when I think about a given patient who I'm seeing, in particular in my clinic. The trial randomized only patients who were successful in that single run-in period. Now, there has been some analysis post hoc of the data of patients who didn't make it through the run-in period, and we await the publication of those data. But I always keep this in mind. If my patient is not yet on high-dose ACE, I'm not going to be as likely to trial them on LCZ696, or what is known as Entresto. Remember what I said about the mean blood pressure. In my heart failure clinic, a mean blood pressure of 120 millimeters of mercury means a patient's not that ill. Most of the patients I see with advanced heart failure have blood pressures in the 90 to 100 range. I think we have to be very careful with this patient group. Not saying they may not benefit, but we have to make sure that we're targeting the patients who can tolerate. Although the systolic blood pressure could be as low as 100 at enrollment and 95 at randomization, the investigators who enrolled patients in this trial elected to enroll patients who were a little more hemodynamically stable. I let that guide me in my own use of this therapy, and in our population, we've probably in the last several months since the medication has been available, given this to maybe 200 to 250 patients. We've seen more symptomatic hypotension and withdrawal of drug for hypotension than was seen in the trial. And I suspect it's because we're using it in patients who have lower blood pressures going in. Again, the vast majority of patients had class 2 symptoms. So I think it's important to think about that when we're thinking about our class 3 and class 4 patients, not saying that they wouldn't benefit, but keep in mind that the trial to some extent was driven by the outcomes in class 2 patients. And again, a minority of patients were enrolled in sites in the United States, so fewer patients had ICD and CRT devices. I think registry data will tell us along the way whether we see in United States populations where patients are treated with ICD and CRT, will we see the same incremental benefit of this medication? Cost will clearly play a role, and I'm going to talk about that right at the end. I'd also like to address the topic of the SHIFT study, because this is another newer therapy, at least newer in the United States, for our heart failure patients with HFrEF. The SHIFT study was systolic heart failure treatment with the IF inhibitor ivabradine, and the trial was pretty similar in a lot of ways to the trial that I just showed you, the Paradigm Heart Failure study. Patients had to have moderate to severe chronic heart failure. They had to have ejection fraction less than or equal to 35%. They did have to be in sinus rhythm, and their heart rate on randomization had to be higher than 70 beats per minute. And they also had to be on best recommended therapy. There was not a stipulation for specific dose of beta blocker in this trial, but investigators were encouraged to advance beta blocker dose in this trial prior to patient enrollment. Patients had to be adults. They could have ischemic or non-ischemic etiology. And in order to make certain that they were dealing with a patient population that was relatively ill, patients had to have a documented hospital admission for worsening heart failure in the year prior to randomization. And this is the SHIFT study design. Patients were screened and then randomized between ivabradine, 5 milligrams twice daily, versus placebo. And then you can see that the dose was up-titrated according to heart rate and whether patients tolerated over a given time. Patients were seen every 4 months, and the study went on for 3.5 years of follow-up. The study primary composite endpoint was that of cardiovascular death and hospitalization for worsening heart failure. And the other endpoints you can see were very similar to the Paradigm heart failure study, including those of composite endpoints, and again, New York Heart Association functional class, patient-reported outcomes, as well as physician assessment of global health. In the total population, 50% of patients had to be on target dose of beta blockers. They met that in enrollment, but not much more than that. So I want to draw your attention to the fact that some of the patients enrolled in this study were not yet at target doses of beta blocker as we understand them. These were the patients enrolled. 6,500 patients were randomized equally between ivabradine and placebo. You can see again, well done follow-up. Very few patients lost to follow-up. The median study duration was 23 months, maximum 42 months. And this is the primary composite endpoint of cardiovascular death or hospital admission for worsening heart failure. Compared to placebo, ivabradine, 18% reduction in the primary composite endpoint, so a significant benefit. This is the endpoint of hospitalization for heart failure. Again, 26% reduction compared to placebo with ivabradine. Death from heart failure, 26% reduction for those patients taking ivabradine versus placebo. So the conclusions of the SHIFT study were that ivabradine significantly reduces major risks associated with heart failure, as I already showed you. I didn't show you some of how the curves separated, but the benefits appeared very early on and were consistent in all pre-specified subgroups similar to the Paradigm study. And these were demonstrated on top of recommended therapy. And the treatment, I didn't show you the slides to demonstrate this, but treatment with ivabradine was very well tolerated. So when we think of our own patient populations who will benefit from ivabradine, HFrEF patients with EF less than 35%, symptomatic patients, they have to be in sinus rhythm. No patients with atrial fibrillation were enrolled. They have to have a heart rate higher than 70 and a heart failure hospitalization in the past year. So with regard to which patients benefit, in general, patients who have persistent higher heart rates after full dose titration of beta blockers are generally younger patients. In my practice, I have used ivabradine primarily in younger patients. Very rare to see an older patient who is still in sinus rhythm who doesn't have reduction in heart rate on higher dose beta blocker. Again, there's more conduction system disease in the elderly. So in general, our younger patients may benefit from this if they have persistently high heart rate. People have asked the question, which should we add first? Should we add valsartan sacubitril first, followed by ivabradine? Completely unknown because this hasn't been studied. Kind of have to take that on a case-by-case basis. This is how the guidelines have addressed the use of ivabradine, giving it a 2A indication, as you can see. Again, for those patients who are in sinus rhythm with persistently high heart rates as defined by greater than 70%. But the guidelines stress that it's important that we fully beta block these patients with guideline-directed doses of beta blockers prior to considering ivabradine. I want to end with this slide and talk a little bit about shared decision-making with our patients. This was brought up by one of the questions after Dr. Chazal's talk. This is showing how much a patient would be out of pocket taking enalapril for a month, $4. Going to Walmart, CVS, you name it, you can get enalapril for about $4 a month. Entresto, if you're paying for it out of pocket, is about $12.50 a day. Now, clearly there's insurance coverage for many patients, and actually most of the payers are embracing this new therapy with lower copays for patients. As time has gone on, we have less need to actually do pre-authorization for these patients. But I think it's important for us in all therapies in medicine to use shared decision-making with our patients. There's a lot of direct-to-consumer advertisement, particularly for valsartan and sacubitril. Your patients may be asking about it. So in addition to sharing the information on the Paradigm Heart Failure study, I also discuss with them the information on cost, and we're hopeful that an actual decision aid may be available very soon. There's some investigators interested in shared decision-making working on this so that we can actually bring our patients more formally into the discussion. But whenever we have new therapies or therapies where there's clearly a difference in outcomes, but expense comes into play or change in risk, I think it's important that we get our patients' input, and I will leave it at that. Thank you very much for having me.